So again, thank you all so much for joining us for this second webinar in our series, Oxygen Series, Care of Pediatric and Adult Patients. Today we'll be discussing pulse oximetry and oxygen therapy in a time of COVID-19. I will let Dr. Weiser introduce all of our excellent panelists in just a moment. Next slide. So with that, I'd like to introduce Dr. Thomas Weiser. Dr. Tom Weiser is Lifebox's consulting medical officer. He is a general and trauma surgeon, a surgical intensivist, and an associate professor of surgery at Stanford University Medical Center. From 2006 to 2009, he was part of the World Health Organization's Safe Surgery Saves Lives program, which developed the surgical safety checklist. Dr. Weiser supported the development of the pulse oximeter COVID-19 decision-making tool. Over to you, Dr. Weiser.
Thank you so much, Monica, and thank you to Assist for hosting this webinar. Welcome everyone to this virtual grand rounds on pulse oximetry and oxygen therapy in the time of COVID-19. Again, thank you to Assist International for hosting this session and to our co-sponsors, the Alliance for International Medical Action, known as ALIMA, Johns Hopkins University, Stanford University, and Lifebox, and to our panel of members, and to all of you for joining us today. The format of this session will be to have a 30-minute panel discussion, followed by about 30 to 45 minutes of question and answers. Again, to reiterate, if you have questions, please write them in the chat, which you can find in the bottom icon of your screen. We will stop promptly after an hour and 15 minutes, but we will do our best to respond to all questions that are posted to the chat. Before I introduce our panelists, let me also say just a few words about the civil unrest that's happening in the United States. I want to let you know that we stand in solidarity with all of those who are disenfranchised. We stand for health equity. We stand for those whose voices are not as powerful as our own. And we look forward very much to supporting all of those who are trying to access healthcare. So we are really grounded in health equity for all. We have three panelists today. Dr. Baweye Mayoum is ALIMA's country representative for the COVID-19 response in the Democratic Republic of Congo, DRC. He's worked for ALIMA for almost 8 years in various contexts of malnutrition, population displacement, various outbreaks of measles, cholera, hemorrhagic fever. Prior to COVID-19, Dr. Baweye managed medical interventions of Ebola with ALIMA in DRC, and before that, he was their medical team lead in Niger, Mali, and Guinea. Dr. McCollum is a pediatric pulmonologist at Johns Hopkins University, at the Johns Hopkins University School of Medicine. He has expertise in global child respiratory health, with nearly 15 years of clinical and research experience in low resource settings in Southern Africa and South Asia. Dr. Eric is currently based in Lesotho, where he directs the Johns Hopkins Global Program in Pediatric Respiratory Sciences and is working to support the government of Lesotho in clinical management of patients with COVID-19, including advanced respiratory support. Dr. Susan Shepard is a pediatrician with over 10 years of experience in child malnutrition and has worked with ALIMA since 2013 on the development of new strategies for managing childhood malnutrition. Dr. Susan was instrumental in the development of the COVID-19 decision support tool that we will be discussing today. As we all know, measuring the oxygen saturation of a COVID patient has become fundamental to understanding how severe a COVID case is. Being able to identify the severity is vital to appropriate triage, whether it's isolation at home, admission to a hospital, or to a high dependency unit, and then also how much oxygen support will be needed. Lifebox and ALIMA has worked to develop a COVID-19 decision support tool to help guide clinicians during the COVID-19 pandemic, and it uses oxygen saturation measurements from the pulse oximeter to determine when oxygen support is indicated. This decision support tool was created as guidance for frontline providers in low resource settings working with patients with respiratory compromise and suspected or confirmed COVID-19. Of note, we've also noted that it's been used even in high resource settings such as New York City. We'll be presenting on this tool today, which is available on the Lifebox website, and we'd also like to highlight the WHO's Clinical Care Toolkit for COVID-19, which is available on their website. We hope that today is an opportunity to share some lessons learned in terms of oximetry and oxygen therapy as we grapple with this virus, and we continue to try and provide the best possible care for COVID-19 positive patients and all of those who are seeking our care. Thank you so much for joining us and sharing your knowledge and experience with us. So let's start with the discussion. And I'm going to turn to all of you, or each of you, and ask you if you would say a few words on the current situation of the pandemic from your perspective, based on where you are, and then follow up with some of your respective organizations and how they've responded to COVID-19. And let me start with Dr. Susan and the ALIMA response.
Thank you, Tom, and thank you everybody for joining us. It's a pleasure to be here today. And I can only be heartened by the degree of partnership that is demonstrated by all of the people from so many places across the world joining together here today. Working in partnership is certainly a core principle for ALIMA. So ALIMA is an emergency medical response organization. It's 10 years old. It's based in Dakar. And about the vast majority, over 90% of the people who work for ALIMA come from West and Central Africa. ALIMA has 40 projects in 12 countries, mostly in West and Central Africa, plus South Sudan. And since early March of 2020, we have launched COVID treatment projects in 5 countries. 2 in Democratic Republic of Congo, 1 in Guinea, 1 in Senegal, 2 in Burkina Faso, and 2 in Nigeria. These projects range in size from 50 beds to as many as 400 beds in Conakry. Most of them are based in capital cities, but the one particular project that I think deserves attention is the project in Beni, where we have been responding to Ebola for the last 2 years, and where we had intended to convert an Ebola treatment unit into a COVID to see Ebola rear its head again. And so we've been managing these 2 epidemics basically simultaneously. So ALIMA works primarily in support of ministries of health, and so I would never speak of ALIMA patients, but there are a couple of projects where we are really in front line. Dr. Baweye will speak about our work in DRC, but our largest project is in Guinea, and we have a 400-bed unit in Conakry that currently has about 392 patients in it. The overall comment that I would make on this epidemic is that it certainly seems to have different character and different profiles in different places. And the types of populations and the time of introduction and of the virus and the way that various authorities respond to the virus is certainly creating very different profiles. From Burkina Faso, where very early there was a high mortality rate, and we were really fearful of a situation that might look much like northern Italy or New York City, which certainly has not bared out, to places that seem to be developing more slowly, like Senegal, where cases kind of have gone along at low level for the first month or 2, but are increasing in number, and mortality is starting to increase as well. So it's going to take all of us thinking together and thinking creatively to develop the most appropriate responses to wherever we happen to be working. Thank you.
Thank you so much, Dr. Susan. Dr. Baweye, would you tell us a little bit about the situation where you are currently based?
Okay, here I'm Dr. Baweye, ALIMA Emergency Coordinator for COVID-19 response in DRC. I'm so glad to join the discussion today because I'm so motivated for these kind of discussions. So I'm going to talk to you a little bit about the context of the COVID-19 here in DRC. So as we speak today, I'm speaking from Kinshasa, which is the capital of the DRC. And the DRC is the 12th African country in terms of recording of the COVID-19 numbers. If you look at in the GS data, up to date, we are more than 3,000 of the case. But the spread of the disease is quite different from the west and the east part of the DRC, in respect that some preventive measure is so difficult to be put in place, especially in the DRC. But the only preventive measure is that the Kinshasa, the capital, which is isolated from the other cities, but inside the Kinshasa is difficult for the social distanciations and also the containment of the people at the house. So what the government has decided is to integrate the response of the COVID-19 in the public health system. So each public health structure of public health systems has to manage the COVID-19, because we know that most of the people are asymptomatic and it's not very easy that we can end this epidemic or pandemic in the next 1 or 3 months. So the reason why the response is completely integrated, and our approach as ALIMA is also to work in partnership with the Kinshasa Teaching Hospital in the case management, and also at the peripheral level with the district health system, how to follow up the contact tracing, and at the level of the teaching hospital, how to design the COVID-19 suspected pathways and how them, because all of those are integrated into the teaching hospital, which is a component of the facility for the case management.
Thank you very much, Dr. Baweye. Dr. Eric, would you tell us a little bit about your context and observations?
Thank you. It's a pleasure to be here today with everybody. So in Lesotho, I think like many countries, there's been a big, I guess, mind shift away from some of the more common issues around HIV and TB to, so shifting systems has taken a lot of effort, but a lot of momentum is now being garnered around testing, getting the proper equipment, and some of the things we'll talk about today in terms of upgrading oxygen and pulse oximetry access. To date, nearly 1,700 people in Lesotho have been tested for coronavirus. Only four people have returned as positive, and there's about 150 tests that are pending. And there's been no fatalities yet of confirmed cases, although there's been several deaths among suspect cases. Our organization, so I'm on faculty at Johns Hopkins and working in collaboration with JPIGA, as you've mentioned. We're supporting the Ministry of Health in the scale up of 17 district hospitals to be able to serve coronavirus patients in a phased approach. And we're starting the first phase really focusing on 2 treatment centers, which are essentially repurposed district hospitals that will be dedicated to coronavirus care and treatment. And so that's kind of where we are today, a lot of capacity building, training, and supportive supervision. Thanks.
Thank you, Dr. Eric. Let me, I know each of you has prepared a few comments and some slides to share with our audience today. So let me start with Dr. Susan. ALIMA was instrumental in the development of the COVID-19 decision support tool. Would you explain it to us, the need and the rationale behind such a tool, and then talk us through the key points, if you would? So Dr. Susan.
Yes, thanks, Tom. So as it so happened that as COVID arrived, ALIMA had been quite involved in a project to introduce pulse oximetry into primary health centers. As many of you may know, pulse oximetry is not a commonly used tool in health centers, and given the prevalence and mortality related to respiratory disease, we were developing a project to determine whether introducing pulse oximetry could improve diagnosis of children with severe respiratory disease and to facilitate transfer to hospital for oxygen therapy. And so it kind of fell naturally to us, to say, well, of course, in the context of COVID, not only is it, not particularly young children, but everybody in all health centers need to have access to pulse oximetry to better diagnose the presumed increased burden of people who will be coming for assessment of respiratory disease. Hence the development of this decision support tool, which was intended to accompany introduction of pulse oximetry into as many health centers as we can. I neglected to mention in my initial remarks that not only have we been working in hospitals, but we're also supporting 100 health centers in 5 countries across West Africa, precisely to introduce pulse oximetry and improve infection protection and control. So in partnership with Tom and several other people, we started trying to come up with something that would be simple, that would fit on a poster, and that could apply to all ages of patients and would guide health workers into when to measure pulse oximetry, and to allow them to then, once using pulse oximetry as a screening tool to identify people that were potentially in need of oxygen therapy, then to then to transfer them to services where oxygen is available. I think that basically the tool has 2 points. Number one, triage and identifying people with respiratory disease and those who have signs of hypoxemia or pending hypoxemia. And then the second part of this, if you can advance the slide, next slide, is to also guide clinicians once patients are on oxygen to titrate the oxygen. And remember that oxygen is a drug with benefits and side effects, and we want to make sure that oxygen is used safely. So to give people guidance as to how much oxygen to use, what saturations to target, and importantly to remember to recheck oxygen saturation and to adjust flow to keep saturations in a reasonable range, 90 to 96%, with obviously special considerations for pregnant women. And then furthermore, to help clinicians determine when the patient is deteriorating, what measures they might take to provide more oxygen, and when it is necessary to transfer the patient to a higher level of care. So it's not meant to be comprehensive. Obviously, there are other measures that could be included here, such as changing the patient in position, lateral decubitus or prone position, to try to improve oxygenation. But it is meant to be a basic guide to help clinicians of whatever level of training to safely and accurately and adequately provide oxygen. So I think that there's the controversial, the difficult point on this slide has actually been the threshold for instituting oxygen therapy. And when the WHO first provided guidance in mid-March, they classified severe pneumonia for adults and adolescents as patients with an oxygen saturation of less than 94%, and in children under 5 it was not less than 90%. We had some debates and decided that, I think in particular for the purpose of triage, given that patients may be far from oxygen, using a more sensitive threshold of 94% certainly does make sense. The subsequent guidance that the WHO put out last week, they returned to a single threshold of recommending oxygen therapy for all patients less than 90%. I would certainly be eager to hear what other practitioners on this web chat may think, or what our other panelists think. But this is definitely a gray zone for when is it important to initiate oxygen therapy, and at what point do we start improving patient outcomes. The next slide just gives a suggestion of this very large data set that was published in The Lancet a couple of weeks ago, which looked at nearly 100,000 patients and was able to examine those who presented with a saturation of less than 94% at hospital to those who had a saturation above. And certainly the saturation of less than 94% was clearly associated with an increased risk of death, and across multiple contexts. So I think that this is still a point open for debate, and undoubtedly we'll be needing some research in the near future to try to improve the guidance that we give to people in the first line. Thanks, Tom.
Thank you, Dr. Susan. And we'll come back a bit to some of the ideas and implications for the tool, for this this decision support tool, as well as possible modifications as we learn more about the disease and its presentation. My next question is for Dr. Baweye. Pulse oximetry and oxygen therapy are the bedrock for the treatment of COVID-19 patients. I'd like to ask you to walk us through the basic guidelines that are being used for the triaging of these patients in ALIMA's work in DRC, if you please. Dr. Baweye.
Okay, thank you very much, Thomas. I'm going to share with you what exactly we are doing currently now in the DRC, especially in Kinshasa Teaching Hospitals. What I want to introduce is that the Kinshasa Teaching Hospital has 1,000 bed capacity, in which the 50 bed, including the 50 bed capacity dedicated for the case management of the COVID case. So each country, according to WHO guidelines, each country has to adapt the guidelines in relation to the resource and also how to allow others' activity to be continued. So the triage unit that we implement in place in line with the COVID pathway, patient pathways, is that we have the unique one triage for all the teaching hospitals. So all the patients coming to the teaching hospital for looking for the care has to be passed through this triage unit. So for now, as Dr. Suzanne introduced, which is ALIMA perceptive in introducing the pulse oximetry at the triage. But the Kinshasa or guideline, which is quite different, because today how to triage people in the triage unit, they based from the case definition. So the case definition is that either the patient came with the fever or sign of the respiratory disease with the history of traveling abroad or in contact with the confirmed case of the COVID-19. So today is we are not using the pulse oximetry at the triage, but we put it in the perspective, of course, to be used in the triage also to modify the tools introducing from the triage if to monitor or to take systematically the oxygen saturation. So the data that I'm sharing with you today is data that we collected from the COVID unit inside the facility. So from the month of May, we admitted 120 patients. Among of them, 63 are confirmed COVID, with 47 came with the mild and moderate symptoms. But unfortunately, we record also 28 cases of deaths. Among of them, only 2 are confirmed. But what we notice inside the unit of the COVID is that 56 patients who come, they receive the oxygen. They receive the oxygen, and with the comorbidities, mostly associated is diabetes and hypertension, which is associated together, and also hypertension at the second comorbidity associated with those patients. But the challenge that we notice is also that among those patients who receive the oxygen, 39 of them who under the oxygen therapies, they came with the oxygen around 60 to 80%. But the challenge we have is that to provide the oxygen and also to start with the non-invasive ventilations. And the problem that we have also is the capacity of the testing, which is not only at the COVID-19 unit, but also at the national levels, because today at the national level, the capacity is only around 350 testing daily as the capacity at the national levels. But we have 2 sources of the oxygen that we are using. One is the oxygen cylinders, and also we have the oxygen concentrators that we are using as the source of the oxygen. So the pulse oximeter, we use it in the unit to allow us to monitor the patient already who are under the oxygen, and in the same time also to titrate the oxygen concentration between the patients, and also how to decide if this patient, they need the oxygen cylinder or they have to be put in on the oxygen concentrator, because the oxygen concentrators can deliver only 5 to 10 liters of the oxygen per minute, but for the oxygen cylinders, we can go up to 15 liters of the minute. So just I would ask we move to the second slide. Yeah, so as I'm saying, what we have noticed from doctor that we decided we'll put the thresholds from 80% the saturations above. If the patient come, we decide to start with the oxygen concentrators and also the nasal cannula. and we titrate the oxygen from 5 to 10 liters per minute. But if the oxygen saturation is less than 85%, we move directly to the oxygen cylinders, and we use a high concentration phase mask, so we can deliver more than 10 liters of oxygen concentration. But between the two, the pulse oximeter will allow us to shift or to titrate, to reduce or to increase the oxygen requirement for the patient. But most of the patients, if they have, when we use the oxygen concentrator and oxygen cylinder, but if the saturation is still less than 90%, with even 15 liters of oxygen, for now, we don't have any other option. But in our perspective, what we are pushing is that in the next weeks coming, and also we received supply yesterday from UNICEF, that we can use the non-invasive ventilators and high flow oxygen nasal concentration. So currently what we are using at the Kinshasa Teaching Hospital in delivering the oxygen and monitoring the oxygen is what I'm presenting and I'm sharing with you now.
Dr. Baweye, thank you. That's incredibly helpful to see what you're doing on the ground in DRC, and understanding how you're triaging some of your resources, as obviously in many of these settings, oxygen resources are very precious. And so understanding how that's being done in real time is incredibly useful. Dr. Eric, I'm gonna go on to you and ask you, I know that you have some particular concerns and some particular techniques around managing children. And so would you make any additional comments you'd like on pulse oximetry with respect to COVID, as well as other opportunities for high flow oxygen therapy? Dr. Eric.
Sure, thanks. Yeah, just to add in a little bit on pulse oximetry, there are some nuances that we've learned over time in measuring oxygen saturation on children that we thought we could share that could be helpful. This is a tool that we've developed, and some of the key points here I would just like to highlight are that with children, some of the challenges around getting a quality measurement relate to cooperation, movement, agitation. And so if it's culturally acceptable, we found that allowing the child to breastfeed during the measurement is something that can be very calming and distracting to the child and allow the device to work more effectively. We also recommend actually on children below 10 kilograms and 2 years of age or 2 years of age, to actually first try to measure the oxygen saturation of the child's toe. I think a lot of us are more familiar in using pulse oximeters on adults and fingers, and the toe, it's bigger. And again, if the child is distracted, such as breastfeeding, the toe, allows you to be away from the child so that you're not in their face. There's a little bit less movement there, and that we found good success in doing that. And just to add on to that, we also recommend holding the extremity gently but firmly during the measurement. So it's not something in which you put the probe on the child and then your hands off. Usually that we find that the child then starts moving and is interested in what's on their toe or finger. And so having a gentle but firm hold, not pressing the pulse oximeter, can reduce some of that movement artifact and make it easier to get the measurement. And so if you look at step 6, there's kind of 3 rules that we use for when we call the measurement final. One is, the first rule is that this oxygen saturation number isn't drifting. And so if it's staying stable for, we say 3 seconds, then that's a check. If the waveform looks regular and high, if you're using a handheld or monitor that has a waveform, we really, that should be something that you look for in order to ensure that the measurement is reading properly. So it really should look like a wave, shouldn't look jaggedy, irregular. And then I think lastly, looking at the oxygen saturation and heart rate or pulse rate value, it needs to make sense. So I found sometimes you just get something that just doesn't make sense. The oxygen saturation is really low, and then the heart rate looks normal, or, so if there's some things that just don't, if those two measurements don't line up and make kind of physiologic sense to you, maybe try a different toe or finger and try that again. So those are just the nuances I wanted to raise for children, given that might be something new for a lot of people on the call today. If we can go to the next slide, we can transition into talking a little bit about more of the modalities that I would kind of categorize as pre-intubation modalities that, as Dr. Baweye mentioned, are kind of the next step in terms of Dr. Susan's and Tom's, ALIMA's really nice algorithm, triage algorithm. This is a little bit off the algorithm. So these are people that are not responding typically to conventional oxygen and need a little bit something more. And I'll just say that, so I'll talk a little bit about heated high flow nasal cannula, and then we'll transition into non-invasive partial pressure ventilation. We're just going to scratch the surface on this. Really probably need a deeper dive into this, but I wanted to at least introduce these concepts, these modalities, given they may be new to a lot of people on the call. So in terms of heated high flow nasal cannula, really what this is that it's a modality that allows you to deliver a precise adjustable mix of heated and humidified air and oxygen. That's at flow rates that exceed the patient's spontaneous inspiratory flow. And I'll talk about that in a moment. That's a really key piece of it. There's no real single definition that constitutes what high flow is. It does vary by rate and age of the patient, particularly as it applies to children. As you can see here on the left side of your screen, there's two cartoons of typical setups for heated high flow nasal cannula. These are both proprietary setups. But the key here is that there's five parts that are pretty common to this. There's a generator on the top left part that often functions also as a blender. The generator creates the flow, and then the blender is what mixes the air and oxygen together to precisely set the concentration of oxygen. If you look down on the A setup, you see that there's a humidifier and heat arrow. That's the chamber, and that humidifies and heats the air. That's really critical for high flow nasal cannula, hence the name heated high flow nasal cannula. The overall circuitry has to be a closed circuit to deliver to the patient. And then at the end there, you can see there's a high flow nasal cannula, which serves as the interface with the patient. That's also critical. So there's basically, on my count, roughly 8 benefits that I was able to count up in terms of benefits for heated high flow nasal cannula. So the first thing is that it's actually just really well tolerated by patients. It's generally felt to be very comfortable. And what I like about it is that given in a lot of our settings, there's not as much experience yet in more advanced modalities such as invasive mechanical ventilation or even non-invasive partial pressure ventilation. This really builds on, I think, a lot of the skills that our healthcare workers have already in place for delivering conventional low flow oxygen. And so I think if we can get these setups in country, in our settings, hopefully rapidly, I think we could really scale this up quickly with pretty efficient and effective training sets. So, some of the other benefits in terms of just the skill matching is that the humidification and heater really helps to thin out secretions, makes it easier for patients to clear them. There's also the high flow rates are nice because it's felt to wash out dead spaces of the respiratory tract. So dead space is essentially a concept of portions of the airway, typically the upper airway, that are not participating in gas exchange. And so the high flow really helps because it flushes those areas out so that there's more efficient ventilation. That high flow also can address the upper airway resistance that is more prominent in children. And it can really also improve inspiratory effort. There's also thought to be a CPAP effect. So I'll talk about CPAP specifically in a few moments, but CPAP stands for continuous positive airway pressure. And the idea with that is you get a continuous pressure that's delivered to the patient, which can help to re-recruit collapsed areas of lung, can also help prevent further collapse. It does help with some of the dynamic pressure volume aspects to breathing to make the lungs a bit more compliant. Now, heated high flow nasal cannula, it's felt to have the CPAP effect, but perhaps in a more mild way. So it's not something that would be the main reason to use this modality. And then if you just look down at this graph, I'll go through this really quickly, and it's just to highlight a few points. So this is a graph of flow as a function of time. And basically the waveform that you're seeing is just the patient's flow that's generated during inspiration, which is above that blue line, and expiration, which is below. And the idea here, just to hit a couple conceptual points, is that with low flow oxygen, which is that bottom red line at 5 liters per minute, what you can see is that the patient's own flow that they're generating goes above the flow delivered by low flow oxygen. And what that does is that the portions of the waveform that are above that red line means that the patient is drawing in room air and diluting the concentration of oxygen. So with low flow oxygen, typically, particularly through nasal cannulas, we don't actually really know for sure what concentration of oxygen we're delivering. And so what this top red line does, that represents a flow that could be given to an adult with heated high flow nasal cannula. And what you can see is that that flow is above the spontaneous flows generated by the patient. And so what that allows you to do is to actually precisely give oxygen concentrations to the patient. So you really know exactly what you're giving. In terms of, and that's a really key point to this modality, in terms of the setup, briefly, the parameters that you want to set up are 2 things. It's the flow rate, and then it's the oxygen concentration. Often for adults, you may start with a flow rate ranging between 20 to 35 liters per minute. And then typically most people managing high flow nasal cannula will try to optimize the flow first and then work on the oxygen piece second. And the idea is you want to try and minimize your oxygen use. So max out your flow and then blend in the oxygen as needed. And one of the other benefits that I forgot to mention with heated high flow nasal cannula is the current thinking is that it does not aerosolize viruses. In particular, we're thinking of course, coronavirus in this context, as much as a non-invasive partial pressure ventilation. So although with healthcare workers, when we're using this modality, we still would want to take airborne precautions. The sense in terms of my reading around this is that the thinking is that there really shouldn't be any additional risk above conventional oxygen. Now, that may change, but that's the thinking at the moment. In terms of the main indication for heated high flow, it's really going to be to address those patients who the conventional oxygen approaches are, your patient is still hypoxemic. And in the context of the current WHO recommendations you may have seen put out last week, really this modality as well as the non-invasive partial pressure ventilation modalities are really focused on those patients in the mild ARDS spectrum. So these would be patients who maybe have a bit more compliant lungs than the more severe presentations. And they recommend trialing heated high flow if you have it for 1 to 2 hours in a monitored setting. And if patients fail this, and what we'll talk about next is potentially transitioning to a CPAP or BPAP approach. Drawbacks to heated high flow, it's still relatively expensive. It's more expensive than conventional oxygen. It does require consumables. So what we're planning on doing in Lesotho is to disinfect and reuse some of those consumables. That can be quite resource intensive. It does require more oxygen. Now, what we're planning to do with the setups that we're going to be using, hopefully, we don't actually have them yet, but they're hopefully in process, is to use oxygen concentrators. And so you can use oxygen concentrators at a flow rate of about 8 to 10 liters per minute, and you should be able to achieve oxygen concentrations delivered to the patient in the range of 40 to 45%. Above that, you probably would need to move to a cylinder. Other drawback is the need for continuous power supply. That can be a challenge, but heated high flow nasal cannula, you need flow, you need heated humidification that requires power. So if we can go to the next slide, we can talk, just skim the surface here of non-invasive partial pressure ventilation. So why would we want to try and use this modality? I guess first, what is it? So this is another modality for providing support to people with failing respiratory function, delivers oxygen enriched gas under pressure using a non-invasive interface. So that's what these masks are, non-invasive interfaces, where compared to an invasive interface would be intubating the patient using a tracheostomy. Okay, so this is non-invasive. The real indication for this, when you would transition to this potentially, would be your patient continues to have increased work of breathing on the heated high flow. Really what we're trying to achieve with coronavirus is as a calm breathing pattern to limit patient-induced lung injury, which can potentiate the ARDS process. Or it may be indicated if you have access to blood gases, which many of us may not. If you do, and the patient is hypercapnic, so high blood carbon dioxide levels, then that's something where we may need to add in this modality to help improve ventilation. And that would really be speaking to BPAP. So those are really the benefits, is that you can probably address hypoxemia better with BPAP, particularly given you can achieve higher mean airway pressures, but also can address ventilation issues. Benefits for this over invasive mechanical ventilation is that it avoids potential trauma to the airway from intubation. You may not need to sedate patients as much. In fact, really should try not to if you can. Patients should still be able to communicate just like they can with heated high flow nasal cannula. They should be able to intermittently eat and drink if they're not a high aspiration risk, and it would help to avoid ventilator-associated pneumonias. Contraindications to this would be really, I think, facial deformities, and then any indication for intubation. And again, the WHO is recommending in the context of COVID, this can be trialed for a couple hours, and hopefully it can work for a lot of patients. So there's two options. There's a CPAP option for non-invasive ventilation, and there's a BPAP option. CPAP, as I mentioned, stands for continuous positive airway pressure. This really addresses hypoxemia by re-recruiting areas of lung that have collapsed. BPAP, which stands for bilevel positive airway pressure. This can also address your hypercapnia through improved ventilation, and also can probably more effectively address hypoxemia by improving mean airway pressures. The key, and getting back to this slide, is really the nasal interface. So you can see, like in children, we typically would start off with either a nasal cannula or a mask, and I would say in adults we would also tend to start off with a nasal mask. On the bottom of your screen, you can see two examples of oronasal masks, one on an adult and one on a mannequin child. The drawback to the nasal approach only is that you have mouth leak often, and that can reduce the amount of pressure you're able to deliver to the patient. The oronasal mask covers both the nose and the mask, so it can address that mouth leak, and it gives you better physiologic benefit but it's also more difficult for the patient to tolerate. And so that's the drawback to that. And then the other drawback to this sort of the full face mask or a nasal face mask is there's a higher risk for aspiration. If a patient vomits, they may aspirate on that. So it really needs to be done under very close supervision. Can you go to the next slide? Okay, so this is my last slide. I'll go through this quickly, don't worry. So there's an example of cartoons of ventilator circuits on the left part of your screen. The bottom circuit, circuit C, so that is, that would be considered basically a standard ventilator circuit. So this would be a device a ventilator that could be used for both invasive and non-invasive ventilation. There's two limbs, as you can see. The advantages to using non-invasive ventilation off of a standard ICU ventilator is that you have these, you can generate higher flow rates, better alarm systems. The dual tubing actually helps to minimize risk of rebreathing carbon dioxide. The top two examples are more like portable or even like portable ventilator circuits that you may see kind of commercially available. You could use at home. These have more limited flow rates, and the single limb tubing does create a higher risk of CO2 rebreathing, just something to keep in mind. Very briefly to talk about the mechanics, I won't go into this in too much detail, I'll just highlight a few points. So the center graph here is the pressure versus as a function of time graph. And so this is looking at the pressure inside the lungs relative to the pressure outside of the lungs in the atmosphere. And what I would say here is just to highlight that this waveform that you're seeing is a normal breathing pattern. So the negative deflection and pressure below zero is inspiration. The positive deflection is expiration. And now if you move over to the CPAP graph on the right, what you can basically see here is what CPAP does is you can see it's delivering this constant pressure, and that's depicted by this red line. And I've chosen a pressure of 5 centimeters of water, which is often a pressure that you would use to start on a patient. And what you can see here is that the waveform, which depicts the pressure waveform of the patient's breathing, it looks exactly the same as it would under just normal breathing circumstances. And this highlights the point that patients are initiating all their breaths, they're breathing spontaneously, but it shifts this curve upward and into a positive, it's fully positive pressure, which again is hopefully the aim of that is to re-recruit collapsed areas of lung, improved mismatching of perfusion and ventilation in the lung. It's called VQ mismatch. And that really the aim of this is really to address hypoxemia. And then, and there's one pressure with CPAP. And the difference here, now if you move down to the BPAP pressure versus time curve, what you can see are two things, is that there's two pressures now. There's a pressure called EPAP, which is functionally equivalent to CPAP. So it's a pressure that's constantly delivered. And there's also now a new pressure called IPAP, which is an inspiratory pressure. And you can also just see the shape of the pressure time curve looks very different than it does with normal breathing or breathing on CPAP. So BPAP is actually changing the dynamics of your breathing. I'm not going to get into super detail here. The other aspects to BPAP that they have different modes. So there's a spontaneous mode, which is what this graph is really depicting. And that's where the patient generates the breath. But the machine is going to support all of those breaths. So what's different here is that the machine is supporting the patient's breathing, whereas with CPAP, the patient is breathing on their own completely. And then there's also a timed mode, or there's also a mode called ST, which is spontaneous timed in most BPAP ventilators, which the timed mode is basically considered a backup rate in most of the setups. And so typically what you would do is you would set a backup rate that would essentially deliver a breath once a certain time has been reached if the patient has not initiated their own breath. So you can see that we are moving more closely to kind of a full ventilation type scenario. And again, the benefit of being able to deliver a rate for breathing is that and just to highlight here, the difference between IPAP and EPAP really represents the patient's tidal volume, and that helps to get rid of the CO2 from the bloodstream. And just to finish up, so the initial settings you might choose for CPAP, as I mentioned, would be ranging between 5 to 8 centimeters of water pressure. And really that could be both in an adult and child. For BPAP, a typical setup would be to start with an IPAP setting of 10. Here it's depicted as 15, but so something in that range, and then an EPAP setting of 5. And then usually people would, if the machine allows for it, would use an ST mode, so spontaneous timed mode, and would have a backup respiratory rate of around 8 to 10 breaths. And that, I'm just talking about adults at this point. In terms of coronavirus, the couple points here with BPAP is that we're really aiming to avoid large tidal volumes. And so you have to be really mindful of your IPAP and EPAP settings. The goal is, I think, again, to kind of have calm breathing and to really, in most cases, particularly if you're moving into a lower compliant lung, which is more like ARDS, is you want to limit your tidal volumes. So I think those are the main things. It's these are just scratching the surface of these modalities, but I'll stop there. Thank you.
Dr. Eric, thank you so much. Lots of information there, lots of good advice and tips regarding using oximetry in the pediatric population, as well as some alternative modes for providing supplemental oxygen for patients who are profoundly hypoxemic. Let me ask the three panelists, starting with Dr. Eric and then moving on. Regarding, there's been a lot of controversy around, or a lot of concern about ventilated patients and the high mortality rate. The growing experience is that the mortality rate may not be as high as was initially expected, and particularly in patients who are younger with less disease, underlying disease burden. But Dr. Eric, tell us a little bit about the situation in Lesotho and how you're managing your ventilator resources and the opportunities you're using to avoid ventilation or mechanical ventilation in your patients. And then I'm going to go on to the other two panelists to ask the same question. So let me start with you, Dr. Eric.
Yeah, so our approach, is really centered around these pre-intubation strategies. So in Lesotho, ventilators are available in the main referral hospital, but there's only a couple. There's only a handful. There are more ventilators that are in the process of being procured, like in many places. But from a larger healthcare workforce, there has not been as much exposure and experience with invasive mechanical ventilation. And so at the treatment centers, I mentioned there's 17 district hospitals, 2 of which are being really repurposed mainly as treatment centers. We do have in our plans with the ministry to support the creation of 2 intensive care units. But my feeling on that is it's going to take some time. Mechanical ventilation, it's not as simple as just using a mechanical ventilator. It's really all the other aspects to it. Intubation is a procedure that can be taught relatively quickly, but managing a ventilator, managing patients with multi-organ complications, it's really a different ballgame. And so I think the idea, our focus is on pulse oximetry, early identification of hypoxemia, administration of low flow oxygen, and if we're having trouble with that on a particular patient, to scaling them up to the modalities that I've just talked about, really trying to avoid the need for mechanical ventilation.
Fantastic, Dr. Ek. Dr. Baweye, tell us a little bit about what the situation is in DRC with respect to mechanical ventilation and the techniques you're using to avoid this, or what you do when patients when you don't have access to this resource. What are the techniques that you're using for your patients in DRC?
Okay, to be honest, in the Kinshasa Teaching Hospital, there is no mechanical ventilators. So the only what they have is they use it in the OT for operations, but in the COVID unit, we don't have mechanical ventilators. So we base mainly on the two sources of oxygen, which is the cylinder and also the oxygen concentrator, in which we move in between. But in the plan for our procurement is that we will not go up to the medical, to invasive ventilations, but we'll keep to the device of the non-invasive, in which I presented before, the Budziak non-invasive ventilation, and also for Airvo2, which is OptiFlow high pressure oxygen. But we don't plan to use any mechanical ventilator.
Are you using proning at all, or are you using other kind of positional maneuvers to help with patients who are profoundly hypoxemic?
Yeah, the maneuver that we use is in the prone position, because when the patient is on the oxygen, either nasal or face mask, yes, we use also the prone position to see if the oxygen supply is if it is good or no. Yeah, also one of the position is also the prone position to monitor the oxygen supply.
Let me ask just another question on this. What are the triggers, or at what point do you decide to turn patients to prone them? What's your procedure, or do you have a protocol for proning of patients, and then monitoring their saturation as you change them from from prone to supine?
Yeah, as I present in the slide, I put it the range when we put the oxygens. When the patient is above the 85%, when we put also the oxygen with the concentration and also nasal cannulas, and when we monitor continue the oxygens, if it's not improved, we decide first of all to change the position from supine to prone to see if there will be improved or no. And also to titrate accordingly. When we start with the 5 liters, then we move gradually up to 10 and changing the positions. But in case that if it doesn't improve, we shift immediately to the oxygen cylinders, and to increase also the oxygen supply above the 10 liters.
Thank you, Dr. Baweye. Dr. Susan, tell us a little bit about some of the other contexts where ALIMA is in place and present. How are you responding, especially in the facilities where no mechanical ventilation is available, and perhaps oxygen resources or oxygen therapy capacities are minimal at best? What's the approach from ALIMA in this particular instance?
So for ALIMA, in COVID or not, regardless of where we work, we always assure that oxygen is available in our hospital units, and we do that with oxygen concentrators, just like Dr. Baweye showed you. And so for the first rule is always do the basic stuff well. And so getting oxygen concentrators into all of the hospital units that we're supporting is what we're doing. I can only echo what Baweye and Eric said, that we have a couple of hospitals in Dakar, in Ouagadougou, in Conakry, where there's 1 or 2 ventilators available. The outcomes have not been good for patients who have been intubated. There haven't been very many. And I can also underscore, obviously, there is a need to increase technical capacity. And I would say that the most glaring need is not even necessarily for doctors, but it's for nurses, like critical care nurses who know how to take care of complex patients with multiple problems. And so I think this is where we're going to be focusing our energies on developing our technical capacities and looking to recruit more nurses who have experience in this kind of highly technical environments. But I just conclude on saying that, oxygen therapy should be available at any district hospital level. And
thank you, Dr. Soon. Go ahead. Did I interrupt you? Sorry. Anything else? No, you're all set. There have been a couple of questions on the chat about concerns for cross-infection using equipment. Dr. Eric, you'd mentioned the concept of decontaminating equipment that is typically manufactured to be disposable, but as we all know, in many places where supply chains can't keep up with demand, there is a tendency to reuse what are typically disposables. What's the general concern about reusing and cross-infectivity in patients, and what are the strategies that you are using, Dr. Eric, and then I'll ask Dr. Baweye as well, that you are using on the ground to try and prevent that nosocomial infection or cross-contamination when patients are using using materials that have been used by another patient or repurposed from another patient?
Yeah, it's a really good question, and it's a real dilemma. And just to say, interestingly enough, I was on a phone call yesterday with some colleagues in America, and they're having the exact same conversation in an American context, which is quite interesting. What we're doing, is really the first idea is to have enough of the consumables that you can cycle them out after a patient uses them, so you can properly disinfect it. So there are different protocols that are typically bleach-based protocols for disinfecting respiratory equipment. We do that, but the idea is, to disinfect it, usually it's about a one-day process, and then have it actually, in our setting, we would dry it outside in the sun until it's fully dry. But it's not ideal, but it's making the best of the resources that we're going to have. Yeah.
Thank you. Dr. Baweye, any kind of thoughts? What are you guys doing in DRC for some of the consumables that are being reused?
Okay, if I can just list what are the consumables that we are using in delivering the oxygen. First of all, we have the nasal cannula, which is most commonly what we are we can reuse, but especially for the face mask, we don't use it again. We dispose definitely, and also humidified for the oxygen concentrator. Those are the consumables that we can reuse, and also with the protocol of disinfections, either according to WHO guideline, using chlorine solution or sulfonyls, that we use this protocol to decontaminate for usual after putting to the sun and leaving completely dry before to use it back.
Thank you so much. And I know that in addition to bleach solutions, which is frequently used, glutaraldehyde is another useful solution for decontamination. Let me also ask Dr. Eric and Dr. Baweye about the use of filters. Obviously, having a filtering mechanism for some of the ventilation devices is really important to stop contamination of the circuit. Could you just, Dr. Eric in particular, could you just talk a little bit about some of the filters that are required, certainly for invasive ventilation, but also for some of the non-invasive ventilations, particularly as it pertains to some of the heated oxygen therapy?
Yeah, I mean, with getting these setups, you do want to use, if you can, there are viral filters that that you can apply to these machines, and so certainly that's something that you want to keep in mind. The other thing I did want to mention that I did not mention previously is particularly with positive pressure ventilation, is that that is considered a more than high flow, more concerning for aerosolization of the virus, and so you definitely want to use airborne precautions with both of those measures. But yeah, the filter, it's a good question around the filtering issue, and it's something that we're going to have to wade through, and I don't know if I have a terrific answer for you on that one.
It's a tricky one. We've obviously been struggling with it, and it goes back actually, in many ways to Susan's point about really the ecosystem that's required. It's not just the physicians. There's a massive human resource component, particularly as Susan mentioned about having nurses available and other trained personnel who can help de-burden the entire system. Earlier in the chat, there's been a number of questions about hydroxychloroquine. Sorry, Dr. Susan, I'm gonna turn you back to you, but since you put it on your slides, it's coming your way. These are controversial data, particularly that article in Lancet. Would you just say a few words about where we stand with hydroxychloroquine as a treatment modality?
Sure. I think that, the honest thing to say today is that we don't have the quality of evidence that would would substantiate a recommendation for treatment, but studies are in progress and we'll see what they show. I realized that when I realized that data is controversial, and I was doing my level best to get the hydroxychloroquine part out of it, but I guess I missed. Even though so I have in no way endorsed or have any opinion at all about the conclusions of that particular paper as regards to the side effects of or the benefits or disadvantages of hydroxychloroquine. They did find that age and body mass index were associated with increased mortality, as was oxygen saturation less than 94%. So sometimes, some of the data may be helpful, other parts of the data may not be helpful. We'll see. But I think we're all learning in real time, and I completely understand faced with tens of thousands or hundreds of thousands of cases, and even with a mortality that is probably somewhere less than 3%. It's a lot of people, and we need to do something. And so, given and hydroxychloroquine is available, and many people are familiar with it, and so they feel like it's worth trying something. I get that, but we need to be careful about. But it does have side effects, and so we need to be careful about weighing the benefits against the risks, and that's what those studies will ultimately help us determine.
Thank you, Dr. Susan. And Dr. Susan, Dr. Baweye, this question comes to you from colleagues in Western Africa. According to your experiences, this is a question in French, but if I've got my translation correct, according to your experiences, what are the issues and challenges of the use of pulse oximetry and oxygen therapy at the primary healthcare center level, particularly in the context of Western Africa, with the other additional concerns of heat, lack of staff, and health system organization? So I know we've discussed a little bit of it, but if you would touch, Dr. Susan, a little bit more, and then Dr. Baweye as well, on some of the particular contextual challenges in your settings.
The contextual challenges of using pulse oximetry at healthcare level, I think, are primarily going to be technical. How robust is the machine? How long does the battery last? How long does the capteur, the sensor, last? In my experience, we've used pulse oximetry in hospital units for as long as I've been doing humanitarian medicine, for 15 years. And it's very intuitive. It's a very intuitive device. People understand it quickly and understand how to interpret the results. So I don't have any concerns whatsoever that nurses or healthcare workers on the front line will be able to use it appropriately. I think Dr. McCollum has done some very nice studies showing how easy it is for healthcare workers, community healthcare workers, to reliably use pulse oximetry. So we'll be left to basically, hopefully identifying the qualities of devices that last for a long time, because if the sensor, wears out after 6 months or breaks easily, then, we all know the real problem is, resupplying, spare parts. So that's my primary concerns. I don't know, Baweye, if you have any other concerns to add to that.
Yeah, of course, as Susan said, the oxygen pulse oximeter has been used in many humanitarian contexts, even at the primary healthcare levels in which we are hospitalized patients. So even one of our strategy is with the COVID response, as I mentioned before, is integrated in the health system, is to go outside the teaching hospital and go to the periphery. But in addition to the technical issue that Suzanne mentioned, is also we have to look at the aspect of decontamination, because it has to move from one patient to another patient. So we make sure that we have protocol of decontamination of the infection before to use to another person. That's all, but it's possible to be used at the primary health care level.
Thank you, Dr. Baweye. Another question actually for you. What are you doing for patients who you suspect may have COVID or exposure, but actually are not hypoxemic? So maybe they have some cough, fever, some shortness of breath, but when when on screening, they don't particularly look ill. Let's say they're at a higher risk, maybe they're a little bit older or they have other comorbidities, but they actually are not clinically ill. How are you managing and handling those particular patients who don't necessarily require immediate hospitalization or oxygen therapy?
Okay, what I have to mention in that, we move according to the guideline. Clearly, what's the national guideline of Congo or DRC state out? They say any patient suspect with COVID-19, either confirmed or suspect but no clinical sign of hospitalization, should be managed at home. So, but at the level of hospital, the reason why by putting the pulse oximeter at the triage will maybe change the decision in case that if there is oxygen saturations is less, decide if the patient has no clinical symptom, but we can decide at the hospital level to admit the patient or no. But from the guideline of Congolese is that if there is no sign, no symptom, the patient doesn't need hospitalization.
And let me follow up and okay, let me just follow up and ask. So, what kind of guidance are you giving those patients who are sent home or are not being admitted in terms of recommendations? At what point do you advise them to come back to seek treatment? What are the recommendations on that side?
Okay, the recommendation is that because each COVID management is decentralized at the district levels, with the medical doctor in charge of the health zone and also the primary health care. So each individual belongs to one of the different level of the health system. So if the person also is listed as a part of the contact, it should be followed by the commission of the surveillance. So they have the community health worker at home was paying visit daily at this patient and to raise any alert if there is any complication to the surveillance team, and they can report immediately to have any decision. So we refer the patient back to the commission of the surveillance at the community levels.
Thank you. Dr. Susan, I think you had something you wanted to say.
Yeah, I just wanted to point out that national policies are quite disparate. And so, for example, in Guinea, any person who is suspected must remain hospitalized, which is how we get to hospital units that have more than 400 people in them. And I think that this is obviously going to have to change. It's not manageable. And so one of our next phases in COVID response is accompanying ministries of health to develop well thought out home-based management of suspected and or confirmed cases who do not require hospitalization. I saw somebody raised a question about home-based monitoring of pulse oximetry. I think that makes all of the sense in the world. Obviously, we're dealing with cost issues and how to make sure that we keep track of the equipment. But there are a lot of types of devices, and the more expensive ones, the more robust ones, obviously have to stay in the hospital. But there are small fingertip ones that are personal care, not very expensive. I know that I've gone across doctors in hospitals in Bamako who just on their own initiative, they just purchase a pulse oximeter for use during the during their rounds that they pass. They pass from one doctor to another as they sign out. So I think that pulse oximetry is far more utilized than we actually recognize, and that lots of healthcare workers are taking their own initiative.
And let me actually ask a follow-up. I know we're coming to the end of our time, but let me ask you, Dr. Susan, regarding that specific thing. How useful are pulse oximeters if you don't have oxygen therapy available? So we've had a number of questions regarding, if you don't have the ability to make an intervention, what's the utility of that diagnostic? And obviously we have, I know that we have very strong feelings that it's very, very useful regardless, but tell me a little bit about your perspective on that. And I'll probably briefly get Dr. Eric and Dr. Baweye as well to comment on that particular question.
Well, I mean, this is what COVID has shown us, that, hypoxemia or, dropping oxygen saturation may be a sign that you're getting worse. And so if somebody can monitor at home and they're 96, one day, and then the next day they're 94, and then the next day they're 93, then that can be their sign that they need to get to the hospital. So I think that in this manner, it may be a very useful surveillance device. As I highlighted in my initial remarks, I think that there's still a fair amount of debate in the medical world about exactly at what number somebody should be put on oxygen in order to reduce mortality. But in terms of a screening device, I think that there's no doubt that particularly in COVID, where hypoxemia is one of the features of severe disease, it certainly does make sense to use it as a outpatient monitoring device or even a home-based monitoring device.
Dr. Baweye, can you make a couple comments about that as well, and then I'll ask Dr. Eric.
Yeah, of course, as Suzanne said, as the screening device is useful and is very, very important. And also in the COVID context, the aim is not only, because we are learning so much about the COVID today, and it can help also at the advocacy, and maybe can move and change also to shift some decisions. But at the hospital level, of course, we have the oxygen concentrator. We are not able to afford all the oxygen concentrator at the different health facility. But we believe that it can also serve as advocacy and also to bring attention to the particular area, because the screening will show the need of the patient that will require the hospitalization or we need the oxygen supplies.
Dr. Eric.
Yeah, I would just add really two things. It's one of the most important tools for assessing risk of poor outcome that I think we have. And so I think that measurement really should be used even in the absence of oxygen as that marker of risk that would trigger a referral, even if it does take time and there's not immediate oxygen available. And in fact, that a lot of work has been done, and there's a lot of stuff out there around oxygen saturation and risk. So even just an abnormal oxygen saturation that doesn't require oxygen can still indicate higher risk of a poor outcome.
Well, listen, thank you all so much. We're about 20 minutes past the hour, so we're about 5 minutes over time. I want to thank everyone for their insights, their questions, their participation. We've been monitoring the chat. Thank you so much. If you still have unanswered questions, we're sorry. We did our best to hit many of the topics and themes that were raised. I also want to thank many people there's many other experts on this call who were actually as part of the chat, and many other people who have a lot of clinical experience answering some of the questions in the chat as well. So thank you for that. Thank you all so much for joining us today and for your questions, and to our panelists, to our hosts at Assist International, and our co-sponsors at ALIMA and Johns Hopkins University, Stanford, and Lifebox. I do want to note there have been some questions about where a pulse oximeter device is available. Not to promote the specific device, but Lifebox is a charity that is focused. One of its core programs is just delivering pulse oximetry devices to resources that need it most, particularly around in the surgery and anesthetic realm, but obviously it's important in many other domains in the hospital and in healthcare. So that is available at www.lifebox.org, and you can reach us through there around seeing how we can help you procure devices for your setting. We really want to express our gratitude and our support for all our healthcare providers around the world as they work on the front lines to tackle this pandemic, and we stand alongside you. We appreciate all that you do for your patients and for your communities. A video of this session will be made available and shared with you. Thank you all for your participation. Stay safe and healthy, and we look forward to continuing our conversation in the near future. Thank you all so much for joining us today.
Thank you guys so much for taking the time to do that with us today. It went really well, and I think we've seen a lot of great feedback in the chats from the people attending. So thank you guys for that. We are going to take a quick poll for those of you that attended this session, just to get an idea of where we are reaching people. So if you have
Sorry, just before we do that, I was on mute. I'm so sorry, I was speaking, and that's probably why you jumped in. So apologies, everyone. I just want to thank the panelists again, Dr. Weiser for moderating, Dr. Shepard, Dr. Barka, and Dr. McCollum. I want to thank our funders and our supporters, GE Foundation, ALIMA Foundation, Grand Challenges Canada, UBS Optimist Foundation, and of course, Project ECHO. And just to note, again, we will be doing a poll. All session information, as Dr. Weiser mentioned, will be available. We'll be emailing it out, the materials and the recordings. We will be hosting it on our website at assistinternational.org. And thank you to Stanford Global Anesthesia. They have been putting everything up on Learn Worlds under the Global Anesthesia and Critical Care Learning Resource Center. I will include the link to that in the chat, but we will also send it out in the follow-up as well. And again, please join the WhatsApp group. We will continue this conversation. The link is here, but email us if you're having problems joining. And as Chase mentioned, and I'm sorry for interrupting you, Chase, we will be doing a short poll now. So if you have the time, please, please, please fill it out. It's really helpful for us. And again, thank you so much to ALIMA, to Lifebox, to Johns Hopkins, and to Stanford Global Anesthesia.